Hi, good afternoon everyone. Welcome to this meeting of the Derby Health and Wellbeing Board. Thanks for coming along on such a cold day. Do we have any apologies? Thank you very much. Any further apologies from the floor? No, thank you. There are no... Oh, there is, sorry, moved on rather quickly. Could you put the... Would you mind pressing the mic, please?
Okay. Hi, I'm Arun Chidambaram, Medical Director covering for Mark Powell.
Thank you very much. Hi, welcome and thank you. So we have no late items, but I would just like to say at this point, congratulations to Cathy McLean, who's just been appointed as Chair of the Derby and Derbyshire ICB. Takes that up in June or July, is it? Later this year? May, as early as May. So congratulations to Cathy. Cathy is a Derby resident. She, before Christmas, was elected as the chair of the National Integrated Care Strategy Board. She was previously chair of the Derby and Burton NHS Trust. So I think she'll be an excellent chair of the ICB, and we can all look forward to working with Cathy. And in the meantime, continue value working with Richard Wright, who's doing a sterling interim job. Okay, so congratulations to Cathy. Are there any declarations of interest? None? Okay, thank you. I know you'll all have read those minutes of the last meeting, and do we all accept they're a true record and happy to note them? Thank you very much. Okay, we've got a busy meeting today. We have quite a lot of items, so I know you've been asked to stick to time, so I would ask you also to stick to time as the chair, so that we can get through the agenda on time. So the first item we have today is the impact report from the Derby Health Inequalities Partnership, and it's going to be presented by Amjad Ashraf and Siobhan Horsley. Thank you.
Hi everybody, we're really pleased to be here today to present our first impact report from the DHIP work. And you might remember that it was just over a year ago was the first time we presented work on DHIP. We presented our consultation and asked for kind of support and governance from the Health and Wellbeing Board. So we're here more or less a year later to tell you what's been going on in the meantime. Next slide, please. So as Councillor Martin said, it's myself and Amjad here today. We're both co-chairs of DHIP. And what we're going to do is to give you some highlights from the impact report, especially the work of the community connectors, and also just start to acknowledge DHIP's potential as it does grow within the city to support planning and delivery in terms of future health and wellbeing planning.
Next slide, please. Okay, so the DHIP journey, very much you could say it began in COVID, during that time where we recognised there needs to be some sort of formal partnership that's dedicated to addressing health inequalities. So as we came out of COVID, we also appreciated that we have to do things differently in order to effectively tackle health inequalities. That pretty much came to the surface during that COVID period. So what that meant for us was a bottom-up approach. So to ensure community buy-in, that we maintained that community buy-in, that we were seeing during that COVID phase, that appetite for change. Sorry, keeping communities at the heart of the work. So it was important that we worked within the themes identified of our membership, and that was very much within sort of co-production and valuing lived experience was at the forefront. And this was reflected in our first theme of regular community consultation and engagement to understand the needs and the human experience behind the stats and data. And what we were seeing was very much delivery plans were based on stats and data, and people weren't taking it on board the human experience, and hence wasn't having the desired impact. And this also allowed us to effectively plan and influence the system on health and wellbeing initiatives. Building community capacity was very, very important. And on the face of it, some would say that, yeah, that's straightforward. But unfortunately, what we're seeing at a grassroots level, it wasn't really happening. So this was in our second theme, the way we were going to do that to ensure the overall well-being, resilience, and sustainable development was through health promotion and education. So this was supporting the development of knowledge, skills, and confidence in health issues, which you'll see is reflected in this impact report. Shaping local delivery plans and addressing the building blocks of health. Again, right from the outset, it was highlighted as essential, and this was to be done via our third theme, which was DHIP acting as an advisory function to the health services and providers to improve their offer for our communities, and also, more importantly, to hold them to account for actions following that advice. So it was important for us to be effective. We must have a strong voice, and as our dear friend and a strategic connector of DHIP, Amo from Disability Direct, said, right in the early days, that DHIP needs to have teeth. So the DHIP now sits on Health and Wellbeing Board and also on ICS Derby City Place Partnership. And it started to organically grow into a point of contact, and some would say a bridge between the system and our communities, and something that hasn't really existed before. Can we go into our next slide? So very much early on in our journey, as we came out of our consultation phase, the findings of that report and a powerful video can be found on our website. We were quite fortunate to attract some funding that looked at addressing health inequalities, in particular the Core 20+5 programme. And this was done via recruiting connectors from within the community that can lead on health initiatives. So the Core 20+5 programme helped us fund 16 organisations that went out and recruited community connectors that supported the reduction of health inequalities, and currently doing that work at both national and a system level. And that work that the organisations and the connectors have been doing and have done is reflected within the report, and each of the 16 organisations, there's a brief summary of what they did and different events that took place throughout it, and over 3,000 participants took part in some sort of event, workshop throughout that last year. Just go into the next slide.
Yep, so you can see then we've kind of split it into waves. So wave one is what's reflected in this report and the highlights that Amjad's just given, and we'll come on to it in a bit more. Our next step is kind of wave two, where we're funding, I think, most, if not all, of the original organisations, plus a few more, to kind of continue and extend this work. It's been funded by Core 20+5 monies, DLUC monies. We've also had some investment from the ICB based on project work, such as hypertension, which we'll come to, and also some vaccination work that we've been doing. So in total, so this is, we're a year in, we've got 56 connectors kind of supporting the work of the DHIP now. Next slide. So, oh, sorry. So we're just going to focus in very briefly on two stories now, and I think both of these stories show just a real ripple effect from this work. So Huram is a pharmacist at Boots and came into DHIP as a community member and also slightly with his professional hat on, kind of wanting to learn more. And he kind of got involved and kind of turned to using his own experience, his professional experience under kind of the Core 20+5 Wave 1, and held a kind of a surgery and workshop in the community around blood pressure checks. And this wasn't something that was standard with Boots, so he kind of influenced his organisation to enable him to go and do that in the community in Derby, and did workshops, held blood pressure checks and so on. And there's kind of a couple of outcomes out of this. So he has fed it back to his manager because they're observing people aren't coming into the pharmacy. There are inequalities in terms of who accesses blood pressure checks in a pharmacy setting. So he has now instigated kind of a boots policy to do outreach for blood pressure checks nationally. And then he's also written up the project and his reflections in an article, and it's been published in kind of the Pharmaceutical Journal as well. So that's kind of another ripple effect in terms of what DHIP have been doing. Next slide. And the next slide is not me telling you about somebody, it's somebody talking about themselves and their own work. So this is Nasheen from Community One. Can you press play, please? Thank you. Next slide. So I think you'll agree that, you know, there's quite a lot of diverse work going on. We've kind of been able to give you a real flavour of that today, but obviously the details in the report. And obviously kind of we've got some foundations now to build on, and our thoughts are thinking about, well, what are our future priorities? And these are developed in partnership with our membership. So what comes through as a real theme in any consultation and any conversations that we have in the community is this kind of concept of cultural competence training and develop. That just comes back all the time to us. So there is some work that we want to develop to kind of think, well, what does this look like? What's important for Derby? How do we explore this in Derby with our service providers and partners and so on? So that's kind of one of the priorities. Otherwise, we want to strengthen the capacity and influence of DHIP through our network of community connectors, our strategic connectors, and the wider DHIP membership. With partners, this is really important, that we want to develop a sustainable funding model for 2024 onwards. We are just funded through grant funding at the moment, so we do want to get ourselves onto a steady baseline model. We know there's lots we can do in partnership with the NHS and others where resources available, and we do want to continue working in that way. So both identifying projects, supporting projects that come to us and evaluating those together. What's also really important and builds on one of our key aims at the start is building that data and insight together, which does include lived experience, which is there for all of us to draw on in terms of our local plans and strategies. And then it's kind of that growing, so promoting and sharing DHIP more widely, strengthening our connections with key partners. Who else can we bring to the table under this DHIP umbrella to ultimately kind of improve the reach of this partnership approach in partnership with everybody here. And next slide.
So recommendations. So we want the board to receive this report and acknowledge the diverse community assets and resources, along with the strong community connections by DHIP during 2023. Again, there's so much work that is happening, yet there's so much that needs to be done. That can only be done with everybody's commitment and buy-in. at a system level, and then also to continue and support DHIP's growth and development into 2024.
Thank you.
Thank you. That's a really excellent and a well-timed summary of, and succinct summary of the report, which is nice and colourful. If you want, it's printed. I have a printed off copy, and it's very informative. There's lots of personal experience and strategic overview. And so I'd like to thank you for the work that you've been doing and congratulate you on it. It's a real model for how we can engage with people in the community and get them engaged and taking responsibilities and use all partners to try and improve people's health. I have a point to make, but before I do make that, do I have any questions or comments? Would you mind just reminding us who you are, please, and which organisation you're from? Thank you.
Thank you, Chair. I'm Arun Chidambaram, Medical Director from Derbyshire Healthcare Partnership Trust. Really pleased to see the number of projects which had mental health included in it. And you mentioned the partnership. I think we'll be very keen. We have been involved in some of them, but equally we've started some work on healthcare inequalities. So both of this kind of dovetail, because we're looking at the data, but if we can combine it with the lived experience, that's what we need. So thank you for the work you're doing.
Did you want to come back on that, Siobhan? Or?
Just thank you, and we're willing to work with you on that.
Councillor Lonsdale.
Hello, Councillor Lonsdale, Representative Littleover. This brilliant project and wonderful. It's probably in the report, but I haven't actually had time to read it completely. So I have a question around, you say you're using sort of community centres as your base and thing. I've heard of a project elsewhere, I think it's possibly in London, that are using places like barbershops for doing really basic health checks, like the blood pressure things, because men are not great at looking after their health, and they're very hard to reach, and sometimes won't even go to like a community centre. Have you considered that sort of way of developing to get those more hard to reach areas?
Yeah, thank you. The beauty of this programme that it's not restricted to a setting, and with connectors originally get recruited via community organisations that are either part of a faith institute or a community setting, but very much are individuals. And we've actually got barbers, and we're looking at different ways. We've actually funded a football team, so a football team that done hypertension checks before having the game, obviously, and other initiatives. So we are very open, and this is what phase 2 is, building upon that, some of the mental health first aid, rolling that out to people at a grassroots level.
Councillor Ashby.
Hello, Councillor Ashby for Councillor for Abbey Ward. Again, thank you. It's an excellent report, and it's encouraging to see and hear what is going on in the community, what has been going on. We're going to have a report shortly on NHS dentistry, and I just wondered whether, as part of addressing health inequalities, whether, education on the importance of oral hygiene and, the very basics of oral hygiene, whether that is, whether you've had any projects on that, or whether that's something that's in your thoughts going forward.
Yeah, it's not something I think specifically, or we're doing some child health.
Yeah, child health and oral.
Yeah, we have done that kind of in a general kind of child health, oral health way. But I know, as that work develops, we can pick up with you later on that.
And just interestingly, yesterday, one of our groups that we funded, Derby Asian Women's Network, because it's been on in the media around child's oral, they're looking at seeing if they can make some changes to their original application to concentrate on the health inequalities faced by young children. So the core 20+5 for young people.
Hi, Lucy Cocker from DCHS, and I think we've already had some conversations in the background about different things that are in the DCHS strategy and how we pull that, how we connect those pieces of work together, because I think the work that you're doing is brilliant. I just wondered, I know that in the report you were saying you were wanting to work closer with NHS partners, and I just wondered how what you were finding as barriers and things that you would find would be helpful to explore going forward.
I think that's probably a whole conversation in itself. And I think where we are with DHIP at the moment, you know, we have a really strong, or develop, you know, we're getting stronger. There's always so much more we can do, but in that kind of community, kind of grassroots capacity. And I think what we want to do then is to kind of bridge some of that with some of our strategic connectors and others to be able to support them into kind of more kind of that strategic position, to be able to work kind of with partners at board level and that strategic level. So yeah, so it's kind of, there's thoughts there at the moment, and then as those thoughts develop, it'll be like, well, actually, how can we make this work? So I know we're discussing coming to the board meeting that you're holding at DCHS, which will be great. I think that's possibly the first kind of occasion that we've been involved in that sort of thing. And think you have a ripple effect at that level, don't you, as well? So yeah, we're taking each step as it goes, and we're just learning all the time.
Yeah, this is an ongoing project, isn't it? And will develop as it goes along. And so I think the model is clearly very effective and very impressive. And I had spoken to Robin Dewis about, you know, expanding the model and focusing on other areas. And I've spoken to Councillor Ashby about some voices that have emerged in Abbey Ward. Sort of underheard voices, should I say. And so there is a sort of tentative thought about trying to kind of extend this model to sort of the Abbey and Mackworth type area, certainly as an idea, and I know you've been very receptive to that, haven't you, Robin? Because some people in those areas have certain kinds of health inequalities that are tied to different kinds of cultural competencies, I think, and or misunderstanding of those. So, and I know there's always limited capacity and limited scope and always more we could do, but I think that will be a really interesting potential, not necessarily the next step, but the subsequent step of this project, which would be nice to see, is taking it out into other areas of the city. So I hope that's something that we can have a meeting about, Robin, with some of the local councillors and talk about possibilities for doing that, because it will require you know, local engagement and perhaps the input from the councillors as well. But so that's something, because it's such an excellent model. And it does seem to be working. So we'll look forward to hearing more updates on this, I'm sure, and talking to you further about developing it. But if there are no further burning questions on this, no, I'd like to thank you very much again for all the work you're doing, and look forward to talking to you more about it. And thanks for the report for today. Thank you. So now we're going to move on to the NHS dentistry report, which has been submitted by the ICB. It's oral health and access to NHS dentistry, and it's going to be presented by Rose Lynch and Clive Newman. Welcome.
Thank you. My name's Rose Lynch. I'm Senior Commissioner Manager for Pharmacy, Optometry and Dental across the East Midlands, but I lead on two system areas, which is Derbyshire and Nottinghamshire. With me today, I have Rami Khatib, who's our local dental network chair, and also Clive Newman from the Derby and Derbyshire ICB. Firstly, thank you for inviting us to come along, and can I say the first colleagues who spoke, the presentation is excellent, and I note the mention about children oral health, so hopefully some of this presentation discussions, and hopefully something we can perhaps work on in the future with them as well. So this update is to provide an update on the current oral health for the Derby population and any ongoing work to mitigate the issues within the NHS dental provision. The next slide, please. Thank you. The contents of this presentation, we're just mindful of time as well, so we'll obviously be quite succinct and obviously allow sufficient time for questions as well.
We do seem to have 25 minutes on the schedule for this issue, but there's because your presentation was colourful, they probably thought, well, they've got colour-coded, so they don't need as much time for people to read it.
That's fair. We'll do our best to make sure we stick within time. So, in summary, the presentation I'll take the paper as read, and the presentation just provides some of the salient points from the report, and we welcome the questions afterwards. We will talk about the National Dental Epidemiology Programme results, then leading on to the longer-term prevention in terms of water fluoridation, the NHS dentistry challenges. We'll touch on that because that can obviously be quite lengthy, and then we'll then discuss in terms of the future strategy. So I'll hand you over to my colleague Rami first, who's going to talk to you about the first two items, and then I'll pass back over to myself. Thank you.
Next slide, please. So my name is Rami Khatib. I'm a dentist, practicing dentist in North Derbyshire and the local dental network chair. So I support the commissioners as a clinician in Derbyshire. We just thought it would be useful to give you an indication on sort of where we are at the moment in terms of epidemiology for dentistry in Derby. So we've got some figures for you. If you can go on to the next slide, please. So the latest survey results from 2022 for children's oral health. This is for 5-year-olds, and as you can see on the graph, this shows that Derby has the second highest rates of tooth decay in the county. So this means that over a fifth of children in Derby have an experience of tooth decay at 5 years old. We know that tooth decay is closely related to levels of deprivation, and the higher rates will be related to areas of higher deprivation and poor oral health. Next slide, please. So for children who do have dental decay, this is again 5-year-olds, the survey shows that in Derby, children have the highest number of decayed teeth. So according to the survey, this shows on average 4 teeth are decayed. These are obviously all milk teeth at 5-year-olds, but they have 4 teeth that are decayed, which is the highest in the county again, and that means that a fifth of the children's teeth are decayed for each tooth that has an experience of dental decay. Next slide, please. On a positive note, the data also shows that there is a decline in the proportion of children in Derby who are experiencing decay. This translates across the country as well. There's a number of reasons for this. Primarily, as was mentioned earlier today, education is one of the most important reasons, and there's lots of initiatives supporting this, both from the NHS and from the local authority, including sort of marketing and education materials for parents and for children. However, a word of caution in that the improvement seems to be stalling since the pandemic, so we are awaiting some additional data from that in the next surveys. So it just means that we can't be complacent, and we need to make sure that we continue all the health improvement measures that we are doing to support children and parents to reduce the experience of decay. So next slide, please. One of the ways to do this is through water fluoridation. Next slide, please. So just to give a little bit of background, fluoride is a naturally occurring substance, and there are lots of areas in the country and in the world that have fluoride in the water, which is naturally occurring in the water. Fluoride is scientifically known to reduce the chances of decay in teeth, and it does this by hardening the enamel of the teeth, but also it has a bacteriostatic effect, so it kills the bacteria that cause decay. So it is very well documented that it has a benefit. As you can see from the slide, there's lots of evidence to show that fluoridation of water is effective, it's safe, and has significant improvement to the experience of all people in an area where there's fluoridation, including children. The data shows, as you can see on the slide, 35% fewer decayed, missing, or filled baby teeth. That's quite significant. 15% reduction in children with decay, so that's 8,500 children across Derby and Derbyshire. So this is very significant results. As a dentist, I can see this every day in children that have the benefit of fluoride, and we certainly provide fluoride as part of the NHS Delivering Better Oral Health toolkit. We recommend fluoride toothpaste and applying topical fluoride for children who attend the dentist. As a parent, I also do this for my children, and I know how beneficial it is. So what we want to ask is for support from all interested parties to consider the fluoridation of water in sort of Derbyshire and perhaps across the East Midlands. There has been a change recently in the legislation in that artificial fluoridation of water is no longer the remit of the local authority, and they don't have to pay for that. It's all done by central government. The process is quite lengthy and complicated, but some of the barriers have been taken away, and the initial step is involving a public consultation in the area where there's an interest. The first area in England is the northeast, but we certainly would want to try and be prepared for Derbyshire and East Midlands if we were to be earmarked by the government that we can support this, this work, because it's clearly very beneficial. Next slide, please. And this is just an indication of the areas in Derbyshire which are already fluoridated. So as you can see, north, east and southwest already have fluoride in the water. But clearly that's not quite enough, and we were hoping to have it across the whole of Derbyshire.
If I may just interrupt, usually I don't, I let people speak and then ask for questions, but I think this is quite, all the points are very significant, obviously, and we're all very concerned about the state of children's oral health in the city and in other areas too. But this particular point is one of the recommendations is that you ask us to support you in requesting from the government for the fluoridisation of the water, isn't it? So, can just for clarity, and I'm sorry if this is really clear to everybody else, but if we were to support that, I mean, would just the scheme, would the fluoridation, or fluoridation?
Fluoridation,
yeah. Would that be, would that entail a process that would apply to Derby only, or Derby in affected areas, or the whole of the East Midlands? What area would it apply to?
So we can't sort of influence that decision completely. It depends on sort of what central government want to do. But generally speaking, to fluoridate the water, it needs to be across the water system that's supplied in that area. So whether that's, you know, as you can see on the map already, some small areas of Derbyshire are included. So it depends on sort of the mechanisms of how the water is distributed in the area as to how you can manage it.
But it wouldn't be the whole of it doesn't rely on the whole of the East Midlands buying in. It could be it's to do with literally the functional mechanism of like the water company's plumbing, if you like.
Exactly.
So it would at least be the whole of the city.
The hope is that it would be the whole of the city and potentially the whole of the county. Yes.
Okay, thanks. Do you have any further slides on this particular point?
No.
Okay. I think this is okay with the meeting. I'm inclined to suggest we talk about this now, and then you can go on to other points which are equally very important, but they're not about the decision on this particular issue, because because you are asking us to, as a board, to support you to go to, as the ICB, to go to government and say, we would recommend water fluoridation in this area, in Derby, and that would involve a public consultation.
Yes.
So I don't know, would anybody, this is something I don't know a lot about. It's something that's come up before. I think when we had the scrutiny board, Clive Newman has been to many boards when I was the chair of the scrutiny board, and he's very long suffering with that. And he's but I mean, it's not clear to me. We obviously your recommendation here, so I don't know what the downsides would be. I don't know why it's been resisted before. Whether that's to do with concerns, scientific concerns, or urban myth concerns, or whether it's just pragmatically an issue with the water companies and the cost. Are you able to fill in a little bit more of that kind of information before I ask for comment?
Yeah, I mean, I suppose it's all of the issues that you've mentioned. Scientifically, firstly, there's overwhelming evidence that it is beneficial and that there is no harm from water fluoridation. As I say, there are areas that have water fluoridation naturally, and there are areas all across the world that have it artificially. The levels that we are talking about is 1 part per million of fluoride in the water. So it is very, very small amounts. As a comparison, in the toothpaste, it's 1,250 parts per million in the toothpaste. So we're talking about very, very low amounts of water. There is, I suppose, on the counter-argument, a concern that we are over-medicating people, that we are giving people something that they haven't specifically chosen to do. I think as a public health body, we have to sort of consider the overall benefits, and this is not unprecedented. For example, folic acid in flour, that's been done, so anyone eating bread, white bread, would have folic acid because of the health benefits that entails. So we're not sort of creating something new. In terms of scientific issues with fluoride, potentially you can get fluorosis, which is where the enamel becomes very white and patchy and becomes very, very hard. But again, this only happens at very, very high levels of fluoride. Again, there are some areas that are naturally fluoridated that have a higher level of fluoride naturally, and that's areas where you can see an element of fluorosis. Now, the fluorosis doesn't actually damage the teeth. It just means that they're a little bit more patchy and white and a bit harder and a bit more brittle. But at the levels that we are talking about, at 1 part per million, there is no scientific evidence that I've ever seen that indicates that there is any harm at all.
So if I can push you on this, and before, I very welcome Councillor Kerr's views on things like this, because I'm sure you've thought about it before, Lucy. So what's the, I mean, I don't need to use, I can't think of a better term, but what's the urban myth concerns about this water, about this process then, if there are any?
I suppose there are people who have concerns about all sorts of things. People link fluoride to all sorts of medical conditions that might affect their children, but as I say, there is no evidence that fluoride does cause any medical complications at all.
Okay, and what are the implications? I mean, other members of the board might have views on that, so I'll welcome all views in a minute, Professor. I'm just going to ask, thank you, what's the, so the cost, the pragmatics of this, the cost, who would bear the cost, that sort of side of it?
So because of the recent changes, the cost is now done by central government rather than the local authority. So in effect, there is no cost to the local authority in relation to water fluoridation.
It is a cost to the system, though. I'm not pushing against this. I'm just seeking clarification. So any cost, we all pay. The government, we all pay the government. The government gets the money from us. So is it an expensive thing to do? What is it?
I must say, I don't know truly what the cost is. I don't know if, Kerry, do you have any information on the costs or?
So I don't know the actual cost, but I don't think
it's an enormous cost. I'm aware that, as you'll see, there's some areas of the county that are fluoridated. I think that's South Staff's water that comes up and touches the edge of the city there. So there will be an awareness in the county around what that cost is, but I don't think it's a huge cost.
Thank you, thank you. That's interesting, thank you. So, Pervez.
Thank you, Chair. Thank you for your presentation, really interesting. As somebody who has lived and worked in Derbyshire all my life, I honestly thought that Severn Trent were fluoridating our water. Honestly, I did. I'm shocked and surprised to learn that they haven't, if I'm honest with you. I really did. I thought that was general normal practice for water to be fluoridated. So certainly I think these things about the dangers and the caveats to them, I think the benefits significantly outweigh those, and you get all sorts of lobby groups and thoughts around the levels of minimal risk around these things, and immunising children, you get a lobby against that as well, don't you? So these things are always there, but it's always proven that the benefits significantly outweigh any of the potential harms that this might cause, and at the levels we seem to be talking about, the probability of that is extremely low. When we are adding fluoride into other products that we use on a daily basis, it just doesn't seem sensible to me not to do it.
Thank you, Pervez. I mean, that's a strong argument. Just before I bring in Councillor Ashby, just for the sake of argument here, because I do like an argument, you know, but, but no, quite seriously though, the Bolsover has fluoridation even, and they have obviously the highest levels of cavities that we've seen. Sorry, that you've seen in Derbyshire on the graph that we've seen. So, do you have a comment on that?
I suppose the decay isn't purely going to be fixed by fluoridation of water. You know, we know that diet is a major issue, education is a major issue. Dental decay is completely preventative. This is the frustrating thing. You know, diet and education and, you know, toothbrushing, oral hygiene is a major component of that. But as I say, overall the studies show for a general population that there will be a significant reduction in the amount of decay, and it tends to be a higher reduction in areas of higher deprivation.
Thank you. Councillor Ashby.
Thank you. Thank you for your report so far. I mean, reading the report that came to us and listening to you is absolutely horrifying in all truth at the level of problems, though I'm not shocked because I've seen it in general practice and seen children, and to me it seems a lot is obviously to do with education of the parents, not just on toothbrushing, but on the drinks that they give their children in particular, and I suspect that's a huge part of it in the city. Like Pervez, I am utterly shocked that all water isn't fluoridated. But maybe that's because I grew up in Ireland, and maybe it has been throughout the country in Ireland in more recent years. I know it wasn't in my childhood, and I know I bear the evidence in my own teeth of that. Do we know what the levels of fluoridation are in Derby? Has there ever been a national programme of fluoridation, or has it always been patchwork all over the country? And could you tell us a little bit more? You mentioned topical fluoride application. Could you tell us whether that's something that has to be done by a dentist, or is that something parents can do at home on a regular basis? I remember we lived abroad at one point and we had fluoride tablets for our children, and then that went out of vogue. So there's obviously a lot that a lot of us here don't know, though we think we're up to date with dental health.
As far as I know, there's never been a national programme of fluoridation. And as far as I know, there's never been fluoridation in Derby itself. As say, the process used to be extremely complicated in the past, and it used to be up to each local area to make their own decisions on that. But the recent change has been welcome, and hopefully that will facilitate a more broader approach to fluoridation across the country, as well as in our area. In terms of topical fluoride, so this is something that has to be applied at the dental practice because it's a very high level of fluoride. But again, this is based on scientific evidence to show that applying this topical fluoride on a 3-monthly or 6-monthly basis, depending on the child's risk assessment, is highly effective. So this is like a sticky sort of jelly solution that sticks onto the teeth for sort of a few minutes or an hour or so, and that will just help to harden the surface of the teeth. Fluoride tablets, supplemental fluoride is also given to children. Again, it's something that's done on a risk assessment at the dental practice, and this can be prescribed to children by the dentist. There are initiatives from the NHS to increase skill mix within dentistry. So there is going to be funding and support for other members of the team to carry out some of this preventative work, including topical fluoride applications, including potential prescribing fluoride products. And dental practices will be remunerated slightly differently for doing some of that work. So there's certainly support for increasing access to fluoridation to help prevent decay in children's teeth. And I say the NHS is putting work already in place for supporting that work.
Thank you. Councillor Whitby.
Yeah, thank you, Chair. I think you partially answered my question, but I was going to say there must be some, or hopefully some statistical information that would demonstrate that there is an improvement with fluoridation. I was going to ask about the 2 areas of Derbyshire, and has there been any, you know, does that show an improvement? But yeah, I appreciate there is a societal angle to this as well, and it is quite a deprived area, isn't it, Bolsover? But even if it's Bolsover, does Bolsover show an improvement since fluoridisation or not? That's the question in a really muddled way.
I don't personally have that data, but we might be able to get that data to report back as to what the levels were before and after fluoridation. Again, I suppose the complication is there's other factors that will have changed in that same time as well. But we can try and see if we can get that data to you.
Councillor, yeah, I've got everybody's thing. I'm just asking, I'm inviting people in order. So the next person is Councillor Lonsdale. Thank you.
Thank you very much for your presentation. I've heard it a couple of times now. Firstly, a couple of years ago on the Adults Health Board, and then recently at my board that I chair, the Children and Young People's Board. I must say, I strongly think this is a way forward to help our children, because I've seen the visible decay on children's teeth, and I have never seen that before in 20 years of working with young people. What was my question? My question is, how much community consultation have you done? If we do get, because I personally am behind this, but if we do get behind it as a board, as a council, how much community consultation have you done? Is there a positive feeling in the community of Derby around this?
We haven't done a community consultation as yet. This is something that we are at the early stages of sort of discussing this with a variety of bodies. For example, we had a meeting with Health Watch earlier this week, and again to give them the information about water fluoridation and to ask them to speak to patients that contact them regarding oral health issues. So we are basically providing the information out there and gauging sort of what level people are with the support. So it's an ongoing process, but obviously at one point there will be a formal process with a formal public consultation and that's the issue that will sort of drive the decision in the future.
Thank you. Helen Dilliston.
Thank you, Chair. So my name is Helen Dillastone. I'm one of the Executive Directors from the Integrated Care Board, the NHS ICB, and I'm deputising for Dr Chris Clayton this afternoon. Thank you for the presentation. As you'd expect from the ICB, we would obviously support what you've set out there. Just a couple of comments and a question, which I think in part relates to Councillor Lonsdale's question as well. So it feels like this is a really important part of the prevention agenda, as well as the health inequalities agenda, and linked to the previous presentation, the pockets that we see across the city. Secondly, just to say that we see quite significant activity through our hospitals for dental extractions in children, which isn't insignificant, and that also plays a really important part. Whilst it hasn't come out in the presentation, just something else for colleagues to note. So that's obviously not prevention, it's sort of treatment, so to speak, which could be prevented as part of a package of prevention measures. And I suppose my third comment is a question, if I may. So is the application to central government on the basis that we have collectively done some consultation and engagement that forms part of the application, or is that a separate process? And obviously the ICB, through our own communications and engagement team, and we work very closely with Health Watch, etc., would support any process around that if that would be helpful. Thank you.
Thank you. Yeah. To add to your point about treatment in hospital, the most common reason why children undergo general anaesthetic is to have teeth removed, sadly. So in terms of consultation, yes, it's basically an application to central government to say, you know, we have undertaken some work with a variety of interested bodies, and we have the support. Please, can you look at our area as a potential for fluoridation?
Thank you. We are sort of running into the next item, but I am going to continue with the debate on this, because I think it's important that people express their views, they get the answers, and then we can give a resounding response to the request for this initiative, one way or the other.
Thank you. I was looking at the data and particularly interested in the inequalities for children with learning disability, because that's a huge issue which continues lifelong. So is there any data that sheds light on what is the need for population in Derby and Derbyshire?
Again, I don't have the data to hand, but we can see if we can get some data. But certainly, I would imagine that people who have sort of disabilities or might struggle to do the normal oral hygiene mechanisms that we do in terms of brushing, mouthwash and things like that, are getting less access to fluoride. So I would imagine that fluoridation of water is going to be helpful, because then they're getting the fluoride through that mechanism. But again, we can see if there is data to support that specifically.
Thank you. Did you want to come back on that as well, or did you have another question?
No, I just wanted just to share with everyone that the reason why we don't have the detailed data with us today is because normally we have our consultant dental public health present with us. Unfortunately, we don't have that. So obviously any data that's required, we can take that back and request it, and obviously then send it through to you. But I'm just wanted to obviously just manage those expectations, and I think this is quite useful, especially from an educational perspective as well, because I didn't even know about fluoride tablets, to be honest. So I think it's been quite educational for everyone today.
Okay, thank you. Yeah, I'm sure that if you can, we can share the data through Lindsay to the whole board if that's what people want, are interested in. I'm not going to take any more speakers because I've got a few more to go through, and we still haven't finished this presentation. So I'll just take the people who've already indicated thanks. And so the next one is Lucy Cocker.
Thanks. Positive presentation again. I was just interested to know, you've said that there's other factors that contribute to tooth decay. how much do people have to be using fluoridated water to get a benefit? So is it they have to be drinking the water? Is it that they, if they just brush their teeth with it, that they would get benefit? I'm just thinking about children, if they're not actually drinking the water, then will they actually see a benefit in it? So that was what I was interested in, really.
So the most benefit would be from drinking the water. So that would be the benefit. But yes, any exposure to the fluoride is going to be of some benefit. So whether they use it to rinse their mouth after they brush their teeth, that would be helpful. Just on a separate note, you're not meant to rinse your mouth after you brush your teeth. You need to just spit.
So I didn't know that until I went to the dentist. So I've been washing my mouth. So yeah, it was the dentist that told me that.
Thank you. Yeah, thank you for that advice.
But yeah, drinking the water is the most effective way for it. I mean, even if they put it in squash or whatever, it's having the access to the water. Certainly, drinking other things that aren't water is harmful to the teeth. You know, the most common thing is fruit juices and fizzy drinks, and it's the acid as well as the sugar that's really harmful. So the assumption is that most people will drink water in some form, and they will have access to the fluoride that way.
Thank you. Yeah, I do. I mean, we really must get through this, but it is very important, and I think that is a really important question, because we know that where some of the people with very small children have the most decayed teeth, they are drinking fizzy drinks almost exclusively from a young age. So that nothing's going to stop the rot, the decays that when that is happening. So, but it doesn't detract, I suppose, from the overall benefits for most children who are not quite in that position.
I mean, as I said, yeah, it's not a magic bullet. It's you know, one part of a whole mechanism. Education is a key component of that, and you know, education about diet, drinks, sugar, and acid is a really significant component of that. But you know, it's everything that helps.
Okay, thank you, Councillor Kerr.
Thank you. When you, Chair, mentioned what the cost is going to be, I did a quick Google search and it sent me to this article, which was actually published this Monday on the Manchester University website, called Future Benefits of Water Fluoridation Not Guaranteed, Study Shows. And I will share the link, actually, if you want to send it out. And it says that over the 10-year period studied, optimal water fluoridation cost £10.30 per person, so £1 per person per year. NHS treatment costs were £22.26 lower per person, and patients paid £7.64 less in dental charges. But it also highlights, which is something I hadn't thought about, that to introduce water fluoridation, there is going to be capital cost, and it says that the capital cost of setting up a new scheme covering a similar number of people, which would be £50 million in today's prices, which would take 30 years to recover in NHS dental treatment savings, which, you know, in terms of total cost is one thing. And I actually think that it gives another angle that we weren't talking about before. And if we were going to be spending that amount of money on, for example, education or on the provision of toothbrushes and experience of schools and so on, that level of investment could get other sorts of benefits in other ways. So I don't think it's an obvious decision. And the other thing that I also think about is, as Chair, you'll know I have an interest in vitamin D, and there is apparently, according to Google, good correlation between children who are suffering from rickets and dental caries. And again, the vitamin D is going to be a factor in whether or not you have strong teeth. So this is clearly one set of information, but I think it needs to be looked at across a broader level of factors to know how we can actually most effectively make a difference. So I would really welcome some broader discussion about this. I have an instinctive feeling that I don't want to mass medicate. And okay, fluoride is present in water naturally in some areas, but it's, as you know, the talk about which water are people using. is really interesting, and the amount of bottled water that people purchase, which then if people are drinking bottled water, they're not going to be impacted by this. And I think that might be a cultural thing as well. So we'd need to look at whether or not that is going to be a factor in inequalities in the future. So I think there are quite a lot of questions on this, but I think it's really important to start the debate.
Thank you, Councillor Kerr. You raised some very interesting points. I think that I'm going to bring in, actually the next person to speak is Robin anyway, Director of Public Health. So I'll let Robin, perhaps she may want to come back on some of that as well as yourself. And then we'll just have Amjad as the last questioner, because I'm really, you know, having said I'm going to be very disciplined at the outset, completely blown that now with this discussion on the timings. What I'm inclined to do then is I'll let Robin come in and then Amjad, and then we'll hear the rest of the presentation, which does, I believe, talk about some of the proposals on education for dental health. And then I think we'll take a view at the end of the whole presentation, then, if that's all right, about whether we feel comfortable in backing this presentation, this proposal now, or whether we want some more information to come back, perhaps to the next Health and Wellbeing Board. So, Robin.
Thank you. And I just wanted to think about that, the issue around the effectiveness in different areas. So, looking geographically, how effective fluoridation has been. And I think certainly last time we looked at this, for the scrutiny committees, my memory was that it's around 40 years or over 40 years since there's been a new area of water fluoridation. I don't know if colleagues, there's a nod. So it's around that period of time. So those areas of Derbyshire where there is existing water fluoridation, it's decades actually since there wasn't. So it's really challenging to see the difference. Although I do think in the back of my mind, there's some work from Birmingham, I think, because I believe Birmingham is fluoridated water, and there was some work done there around tooth decay, which might be helpful to give us that information that we want. It was just, and on that, the capital cost and the introduction of the fluoridation, obviously if it's been 40 years since it's been done, it's not something that we have that really good understanding about what the total cost would be. The cost that the county council will have been paying for that fluoridation before it transferred nationally will have just been the ongoing costs each year for continuing it. Just to think about the not just the physical harms for children, but to think about the impact of dental decay on children and their development as well. So we know that children, and that was a large number of decayed teeth that those children will have, they will be living in pain, they will not be sleeping well, they'll be struggling to concentrate at school, and it's inevitable that that's going to impact on their life chances, not just on their physical health at that time. And just on that issue around further conversation, I'm aware that Nottingham and Nottinghamshire have also been having conversations about fluoridation. And from that historic, looking into this previously, my understanding is that from a water quality area, thinking about the area for fluoridation, that it did include at least some of Nottingham or Nottinghamshire if we needed to do that. So I understand there have been quite supportive conversations in that area around looking towards fluoridation. So perhaps that's something we'd want to think about for that further exploration, actually having conversations with our neighbours as well in that.
Thank you, Robin. Amjad, do you need to ask your question? Is it a bit... You need to speak to the mic, but is it? Well, as it's, please ask the question then, but we need to keep a brief answer, and I'll let you come back also on the comments of Councillor Kerr, which you no doubt want to, and then I think we'll carry on with the rest of the presentation very quickly.
Yeah, so I was just saying there was two questions. First one was the ethnicity data. Do you have any, when you're breaking it, some of the stats? And the second one's around allergens. What's the allergen data to fluoride?
Yeah, so again, I think we'll get the data to you from our public health consultant. I don't have that data to hand, but yeah, we'll send that across.
And did you want to respond to Councillor Kerr now a little, or?
Yeah, I mean, in terms of the cost, I'm not familiar with that paper that you've sort of quoted, if that's been published recently. The general research that I have seen shows that the cost of fluoridating an area overwhelmingly counterbalances the benefit and the cost saving as a result of it. But again, you know, we will look at any sort of new evidence that comes and any costings of that, and we'll try and send you across some additional data in relation to that.
Right, thank you. So we have massively gone over time on this, but if you wouldn't mind continuing with the presentation, and then we'll come back to a view on the recommendations at the end. Thanks.
Yeah, sure. Thank you, Army. Appreciate that. Next slide, please. Okay, so I'll talk to you about the NHS dentistry challenges, which ties in with what we've already discussed in terms of obviously tooth decay, and then obviously children in pain, etc., and then obviously the access itself. Next slide, please. So the national challenges stem down to the ICB challenges as well. The main challenges, as we all know, is gaining access to it. It's been an issue before the pandemic. If anything, the pandemic has exacerbated the current position. So we are well aware of the access issues, and that's not something that we hide behind. There's also the other challenges is the workforce and recruitment of dentists as well, and the wider clinical dental team. But we are working with the Health Education England in terms of how we can make those packages attractive for dentists to stay within NHS. So say, for example, you went into a job, you wouldn't just go into a job just for the financial side. You'll look at obviously what benefits there are for yourself, perhaps for your family, progression, etc. So it's about building that as part of a education and training package for those dentists and that clinical team in terms of what the NHS can benefit them, so that actually gets that uptake in terms of staying in NHS. In terms of the, there's also the discontent with the current contract, in that it's not remunerated to a point where dentists are obviously being remunerated correctly. So, for example, during COVID, dental practices were closed, which meant that lots of patients were partway through treatment. There's been a delay in terms of patients accessing a dentist. So now patients that access a dentist are requiring longer treatments. So the current banding for a dental practice, it's not remunerated enough for them. So it's about obviously changing that contract, and we have done some, well, the government has done some contract reform in terms of changing the payment mechanism, but there's still further work that needs to be done. There's also, with regards to the children we spoke about earlier in terms of water fluoridation, what adds into that as well is also the cost of living crisis since late 2021, where you see more and more families being reliant on the food banks. That again affects your children's diet, and it then has that knock-on effect, and it then comes back to us, the ICB, in terms of that dental access and trying to increase that access as part of that restoration and recovery from obviously the pandemic and the challenges that we had previously. Next slide, please. I'll just quickly go through this, because I'm just mindful, obviously, time and others who have papers to present as
yeah,
well.
very sorry, it's entirely my fault, but if you will have to speed through this if that's
I will
all right.
speed through. Okay, so the first part in terms of restoration and recovery commenced in 2021. We then immediately moved on to Access Initiative, and that was additional investments to help increase capacity for patients, and that was started in 2021 to 2023. In the March to July, we saw the journey of NHS dental services being fully delegated to the ICBs from the 1st of April. So myself, I'm part of the East Midlands Primary Care team, and I was stupid over to the Nottingham and Nottinghamshire ICB as the host organisation. But I work on behalf of all the ICBs. And we do have a governance structure that's agreed, so that obviously we can have that general agreement in terms of governance approvals, and it's ensures a smooth transition as well for the services and also for the patients. The data to date, well, it wasn't to date, it was at the point when the paper was written, at the latest data that was available. So from at November 2023, within the ICB, so that's Derby and Derbyshire, the access was at 98.7%. So it has been growing since the pandemic, but we do recognise there's still a lot more work to do. Can I have the next slide, please? I won't go through every single recovery initiative, but on the left-hand side, that was a continuation from 2021 and 2022. That went to 22 and 23. The right-hand side is 23 and 24, and the couple of elements in 22 and 23, they're the initiatives that have continued into 23 and 24, but also I wanted to highlight as well, at the height of the pandemic, access was a lot challenging compared to it is now. I know it's still challenging now, but I just want to thank the dentists out there who came forwards and provided voluntary urgent dental slots, because we saw 111 under pressure as well. So say, for example, a dental practice may have 4 urgent care slots. They gave up perhaps, say, 2 to 111, so that could help the patients in terms of that patient flow. And they are still standing till today. So I just want to say thank you to those as well. So that actually has helped in terms of working together. Can I have the next slide, please? These next 2 slides are just about the data for the percentage of adults seen by a dentist pre and post-pandemic. So it shows data from 2015 to 2023 in Derby City. You can see there's a growing uptake since the pandemic, but you can still see that's still a long way to go, because at 2023, it's at 47.1%, and the highest growth was at 50.6%. And then when the pandemic hit, that obviously reduced straight down to about 46%. So we do recognise there's still work to do, but it is above the England data, and even though it is, that doesn't mean we stop and sit and not do anything about it. We still need to obviously improve that oral health and that access for our patients, both adults and children. Next slide, please. So it's the same data set, but for children. And again, there's still a long way to go. You see a very large dip in 2019. From 2020, when the pandemic hit, it was at 62.3%, and it significantly halved in 2021. That could be down to the unknown about the virus, parents or carers' reluctance to take the children to a clinical setting due to the risk of exposure. But now, obviously, we're now living with with COVID, it's now starting to increase. But it's about getting that access into NHS dental practices. But we know about the challenges in terms of the workforce and the capacity issues that has. Next slide, please. So the final slide is about the collaboration and future strategy in terms of how we're going to increase that access. So the ICBs took on the full delegated commissioner.
I'm ever so sorry, Rose, but I am entirely responsible for this, but can I ask you to give just a few words summary
okay,
of
that's
this?
fine.
And
okay.
people can read this, and
okay, that's fine.
I know it's very.
It's fine. Sure. Okay, in high-level summary, collaboration, future strategy. We are now the ICB. We're all working together collaboratively with also the local community, and it's about working together in that integration agenda as to how we can commission place-based commissioning to get to the heart of where the population needs that access. We do have a rapid oral health needs assessment that's due to be completed end of March this year, and that will indeed tell us in terms of where those high areas are in terms of risk, so that we can obviously commission the right services in that area to ensure there's sufficient dental access, and whilst obviously we're waiting for the new contract, but there is obviously a lot to do still. Is that okay?
That's excellent, thank you. And I'm sorry to rush you through the important local initiatives that you are taking. We do thank you for that. I know that it has moved, your commissioning has moved over to the ICB. We spoke to you quite a lot at the scrutiny board, I remember, and Clive, the long-suffering Clive. And I know that this is really important work, and I'm not going to allow questions on it now. I apologise to the room, but I felt it was important to focus on the specific decision you wanted back from us, which is what we've done. We can bring this back again. So I'm sure that Rose and Clive will take questions via email, and we can also bring this back fairly soon to look at again, see how what progress has been made with respect to local initiatives. We did discuss dentistry last night at full council. this local initiative work was recognised by, particularly by my colleague, Councillor Lonsdale. We will be contacting the government to ask them to do more to reform the dental contract and to get the funding arrangements sorted out. So I'm going to be doing that on behalf of the Health and Wellbeing Board and with the backing of full council. So provided everybody's okay with that, which I imagine you are, thank you. So what I'm going to do now then is to, I think we need a decision on whether we want to support for now this idea of supporting a consultation. I suggest that given that some questions have been raised, we take a view on whether we support the idea of a consultation and then look again. Is it possible to do it that way as a procedure where we support the consultation but we express another view when we perhaps got more information and when also the consultation, when we've got the feedback from the consultation if it happens?
Yeah, that's certainly right, yeah.
So, is that okay? Are the room okay? Are you all okay with that? That we look at whether we want to support a consultation rather than, because some people have, not many, but a minority of us have raised serious concerns about whether this is not an ineffective measure, but whether it's the most cost-effective measure. So. I don't know. Do the majority? I don't particularly want to take a show of hands, but I'm happy to. You would like me to take a show of hands, Councillor? No. Does anybody? Are people happy with the view? Because my sense is that the room would definitely support the requesting a consultation. Is there anybody who wouldn't agree with that?
I suppose my view is that I think we need to look more holistically at what are the best ways forward. Fluoridation is clearly one of the building blocks that we could use, but are there other building blocks that we are ignoring by concentrating on that one? And that's my concern.
Can I suggest, Councillor Kerr, because I do think that's a valid point. Can I suggest that, I have rushed through the second part. It's my fault that you've rushed through the second part of this presentation, but could we ask maybe, I think the majority of the room is supporting the fluoridation, we go to consultation on the fluoridation, or we ask you to ask the government to do that. I think we could also ask you to come back, because this is an issue that this council is particularly interested in for obvious reasons, whether you could come back to us and give us more detail, which you've not been able to do today, on some of your education initiatives and some of the other initiatives that either are happening or could happen if you had the funding and the focus, to particularly with respect to preventing decay in children's teeth. Is that a good idea? Are you happy with that, Robin? Rose.
Hi, yes, thank you. Just to say, we do have a Derby City Adult Scrutiny Committee on the 30th of January this month. So the second part of my presentation, it will go into more detail in that meeting if anyone wanted some context to...
Which meeting is that, sorry?
The Adult Board on the 30th.
Oh, the scrutiny meeting?
Yes.
Yeah, okay, you're presenting to them again. Oh,
yeah.
you love coming to Derby, don't you? In Derby about the dentistry, so thank you. I think we may have some more. They have specific questions.
That's fine, yeah.
Yeah. Thank you. Okay, right. I am now very behind time. Thank you. So we'll move quickly on then. Thank you very much for all that and your input. That's really helpful. To the Derby and Derbyshire Air Quality Strategy, which is being presented by Carl and Robin. Thank you.
Thank you. And I'm going to just give the background. Carl is here for his expertise and any specific questions that I would definitely be unable to answer. He's here to support that. So what we've got here today is the Derby and Derbyshire Air Quality Strategy, which is the 2020 to 2030 strategy. It did come to the Health and Wellbeing Board
a few years ago, but there's been some work to refresh the strategy and particularly looking at the measures, and that's been one of the key developments. So the Derby and Derbyshire Air Quality Working Group reports through to the Health Protection Board, which obviously then reports through to both Health and Wellbeing Boards. The strategy is here for you to see. It goes into the importance around air quality and the actions that we can take. I think it's just really to pull out that the three key priority areas for the strategy are thinking about our travel behaviour and how we can encourage people to change their travel behaviour, particularly thinking about walking, cycling, or if we are using transport, using public transport. Thinking about how we reduce all sources of air pollution, and that is transport, but it's also thinking about how we heat our homes and other heat sources as well. And then thinking about the disproportionate impact that poor air quality has on some of our either more deprived populations or populations that are more vulnerable due to their significant health issues. So they're the three key areas of priority for the strategy. There's been the development, as I said, of some much more specific and measurable measures which are included towards the end of the strategy, which the working group will be monitoring. And we would like to come back and to report progress to the Health and Wellbeing Board. I'm just going to see if there's anything Carl wanted to add.
Only, I suppose, just on the sort of wider picture of where this is coming from and probably things that have been happening nationally while this strategy is being developed that potentially do influence it and the way that we sort of respond in terms of air quality action. Probably not so much things have changed, but things have been added in terms of our focus on the pollutants of concern. For quite a few years now, the main sort of focus of concern has been in relation to nitrogen dioxide, which sits fairly squarely with traffic-related emissions. And so lots of the measures that we've put in place across the city and county have been focused on, in fact, almost solely focused on traffic, reduction of emissions from road traffic in terms of improving the emissions from vehicles themselves, converting to low emission vehicles, but also obviously sustainable transport measures, obviously moving people away from using vehicles and onto more sustainable forms of transport such as walking and cycling. That hasn't necessarily stopped and changed, but what happened under the Environment Act 2021 and really came through in 2023 was that a new target was set for fine particulate matter, referred to as PM 2.5. So these are the very small particles that can get into your bloodstream once inhaled. And we have a new target, essentially, that is now a legally binding target for the Secretary of State at DEFRA. And it is a sort of relaxed in a sense that it's a 2040 target. But I guess the key point of this is that the main sources of PM 2.5 pollution aren't necessarily the same as the main sources of nitrogen dioxide pollution. Road traffic certainly plays a part. Roughly 10% of PM 2.5 emissions that we see nationally come from road traffic. So you can see straight away from that we still have an issue with 90% of PM 2.5 emissions that are associated with other sources. The key one being focused on by government and obviously passed down locally to us is in relation to burning of biomass. So there's a particular key focus now in terms of trying to control emissions from domestic burning, both sort of bonfires and also trade-related burning and in particular log burning used as heat in log burners in dwellings. So that's sort of the main changes really in terms of the focus. The strategy picks that up still. It doesn't need changing, but there is obviously as it was drafted, a lot of key focus on transport and sustainable transport measures. So I guess it was just worth pointing out that is still there, but there is now sort of a drive to focus more on this domestic burning issue and PM 2.5.
Thank you, Carl, and thank you, Robin. And Helen.
Thank you. Thank you for the presentation. Really welcome the strategy. Couple of comments and then perhaps a suggestion, if I may. So the NHS as a family has a really important part to play, I think, in this strategy, both as a contributor of emissions. So colleagues may know one of the number of contributors to carbon emissions from the NHS comes from the use of anaesthetic gases, both in the acute setting for general anaesthetic and all of the operations that are undertaken, as well as then inhalers, so people that have respiratory conditions, asthmas, etc. Secondly, travel and transport. So we employ over 30,000 people across the city and county that are coming in to our different NHS settings as members of staff, and goodness knows, of course, how many people travelling into our hospitals that are visiting patients, of course. So that is a significant issue for us too. And then thirdly, heat sources and the source of heating that some of our older buildings across our NHS estate use, etc. So in summary, so we have a green strategy, as you'd expect. Part of the role that I have is helping to coordinate and oversee that with each of our NHS partners. Two of our priorities is around travel and transport. The first one being travel and transport, the second one being anaesthetic gases. Both, I think, as well as heat sources, of course, plays into, really nicely aligns with this strategy. So it's really good to see that, and also how we can contribute towards delivering the target. And the second point to make, if I may, is around the importance of our anchor work, and as an anchor organisation, and many of us represent anchor organisations and a way of working. And Chris and I met with Andy Smith, who I think is leading that from the council's perspective, only last week actually, to see what more we can do around that. But again, that feels a place where some of what's trying to be achieved here could also be helped through that work of Anchor as well. So just a couple of thoughts there. Thank you.
Thank you, Helen. Yeah, one of the 2.3 recommendation is for partners to support the delivery of the strategy, including consideration of these priorities within their own organisational strategies. So I can see that you have taken that on board. And the issue of transport is just have to go to the Royal Derby. It's a nightmare, car-wise, and etc. I'm just going to have a few more questions on this because we are running behind time, but it is really important. It is really significant for me and for all of us, really, in the city. Councillor Kerr.
Yeah, I'm clearly the outside air quality is absolutely vital to all of us because all the inside air comes from the outside. So therefore, to get our transport policies right and to minimise the pollution from bonfires and so on is absolutely vital. But people spend maybe 4/5 of their time inside a building, and therefore the air environment which they are exposed to the majority of the time is that internal air quality. And I think in terms of the health and well-being perspective, as opposed to a wider council perspective, we maybe need to be thinking more about how we can provide advice and guidance and awareness about the importance of a good indoor air quality. There are some things, damp, mould and condensation is big news at the moment, particularly because of the season of the year, but for other reasons as well. So that is an element that is being dealt with separately, but there are other reasons for there are other elements that we also need to be thinking about in terms of your internal air quality, to do with volatile organic compounds, to do with the NO2 from if you've got a gas cooker. So I just wonder whether we need to be doing a little bit more work on this from a health and well-being perspective, as well as specifically from the sort of external environment perspective.
Thank you, Councillor Kerr. Would you like to respond to that, Robin, or Carl?
I think they're all really valid points. I think the challenge for us is the need to focus our capacity.
So I think we can definitely think about whether there's some communication messages that we can share about those areas, because you're absolutely right, the indoor air quality is really, really important. But I can give that feedback to the working group and ask them for their thoughts on that.
Thank you, that's really helpful. I mean, just before I bring you in, Carl, and this is a point to you as much as anybody, I suppose, especially to you actually, that it's very important as we, I know this is obvious and I know this is what you do, but just to reiterate that, you know, any message we give has to be absolutely based on evidence, it has to be, and the effects of messaging where we do not want to cause alarm, where people take away one source of heating, say, that they may have, which just renders them so cold they suffer from hypothermia, so they develop other problems. So, as we all know, there's a balance of risk in the way we live all the time, has always been the case. And therefore, you know, obviously, Robin, I know you would do this anyway, but so I agree with you, Councillor Kerr, we probably need to know more. So I'd suggest we know more, we get more evidence, and we have more research and advice before we go ahead and give out public health messages as a council. But Carl.
Thank you, Chair. It was just to make a wider point about this indoor air quality, which is something that does come up at our air quality working group with the county and city. I guess in environmental health, we are obviously come from a regulatory perspective on air quality, and so it was just to highlight really that the current legislative regime is purely focused at the moment on outdoor air quality. We're required to produce annual reports, to declare air quality management areas, to produce air quality action plans, all relating to outdoor air quality. And as it stands, there is nothing that I'm aware of that compels us as a council to do something in that kind of vein in relation to indoor air quality. But it is certainly an emerging area of work, and I don't doubt for a second that there are discussions going on in Whitehall at the moment in terms of, you know, what more can be done and whether it needs to be legislated for, aside from, you know, work going on to improve housing conditions and those kind of things, which obviously do influence that area. I guess it's the same answer in some respects to your question, Chair, that in terms of the messaging, largely that is coming from central government. We act under the local air quality management regime, and all the work that we do is underpinned by science generally produced by the government and their scientific advisors. So, you know, this discussion, particularly regarding domestic heating and wood burning and things, that is all coming from, you know, the government's current air quality strategy based on scientific evidence.
Okay, thanks for that clarification, Carl. I mean, I think I am inclined to move on now simply because we're behind time. There is more we could say. I think Councillor Kerr does raise a very good point. We're not obliged to act on this at the moment, but I think it's something public health can be aware of and have a growing awareness of. We can look at it again and think about it and be informed by it and reflect on it and perhaps go back to government. We're not, I mean, you know, I appreciate they do determine a lot of measures, but it should be a two-way dialogue between local areas and authorities and government. So it's definitely something to have on the radar, Councillor Carr, I agree, even if there's a limited amount that we can actually do on that at the moment. So is everybody happy to accept those recommendations, to note this air quality strategy, to note the structures in place to deliver the strategy, and also to consider how these priorities can be implemented in your own organisations? Are we all happy with that? Thank you. Okay. Thank you very much, Carl and Robin. I'm going to move on now through Robin on the health protection, Derby and Derbyshire health protection strategy.
Linz, I think your Lenovo alert message, we've all been struggling with these, haven't we, over the past couple of days? Wonderful. Wonderful, thank you. So what I've got just to talk through with you is the health protection strategy. So the Health Protection Board that reports to both City and County Health and Wellbeing boards. I'm the chair of that board, and we've just updated, redeveloped a strategy for the work that we're undertaking. So within your pack, there's a plan on a page, and I've just got some slides really that run through that just to talk through. This work's been undertaken with partners across the system, just really, health protection is a huge area of work. There's a lot to do, but just really trying to work out what the priorities are going to be. And just specific thanks to note that this work's been undertaken by Rebecca Symes, who's a registrar that was with us in Derbyshire. So I'm presenting her work as opposed to mine. So as you'll see, a summary of what the vision and the objectives are for the strategy. So it's very much around working together, protecting people, and that's from infectious diseases and from environmental hazards, and minimising any negative impacts of those hazards on health. And what we've done is to try and weave this together with the integrated care strategy, and to think about categorising our areas of work under start well, stay well, and age well and die well, so that we can fit these areas of work together. Thanks, Linz. The one before that. Yeah, that's the one. So how we're going to achieve, so we were thinking about three main themes of prevent, prepare and respond, but then also acknowledging that as Director of Public Health, Ellie in the county and I have a particular role to be assured around the preparations of the system to respond to health protection incidents. And so we were thinking around those four key areas. And this is across a broad range of health protection areas. So thinking particularly around infection prevention and control, and that work's been really highlighted over the pandemic, particularly with our work around community settings and care homes. Communicable disease control, so this includes outbreaks of communicable disease and also TB management. Vaccination and immunisation along with screening, and they are services currently commissioned through NHS England, which are in the process of being transferred through to local ICBs, and we're working really closely around the assurance of that transfer. Emergency preparedness, resilience and response, so that's our local resilience fora. Environmental health, including air quality and climate change, and also sexual health as well, which is something that we've not included in our health protection work previously, but the need to join up some of the outbreaks and incidents that happened through sexual health as well. And all of these things to improve health and well-being, and importantly, health protection issues, again, disproportionately impact on our most deprived populations. So thinking about how we achieve more equitable outcomes. And we've identified 6 areas of focus, not that we won't be covering all of these areas, but thinking about where do we start and where do we put our most energy for this work. So it's the next slide, please, Linz. Thank you. Sorry, I hadn't moved mine on, but they're not connected, are they? That was my... So we're also thinking about our enablers and what are our barriers, what issues do we need to work on to ensure that we can undertake this work. So first of all, communication and coordination. It's a relatively complicated system, health protection. We have the UK Health Security Agency as a new organisation that's we're still working out roles and responsibilities following changes from the pandemic, but also thinking about new structures within local health services as well. Thinking very specifically about our workforce, and we have experienced particular challenges around infection prevention and control services, around finding the skills and the workforce to deliver those roles, but making sure that not only do we have the specialist roles, but health protection is part of everybody's thinking when they're working within these services.
Thinking about how we improve the sharing of data and surveillance and intelligence, and that's some ongoing work that we're undertaking with the UK Health Security Agency. We had really good visibility of the COVID data. Eventually, it wasn't initially, but eventually we did have really good visibility of that. And we think there's more that we can do in sharing that data and seeing that local visibility. So making sure we have that strong accountability and governance. This is through the Health Protection Board, but also I've been working to link the Health Protection Board through to the integrated care system structures as well. Joint working across all of the system, and importantly, including the VCSE within that. And then thinking about strengths-based approaches and our community assets. We know from the work with DHIP through COVID how amazing that work was and what a difference it made. And it's making sure that we don't lose that learning and take advantage of it for future work. So the final slide, thanks. So our 6 areas of focus, and acknowledging that actually some of those enablers that we've identified we need to focus on in order to get the work to move forward. So the first one is around our communication and coordination between partners. And as I mentioned, we've started this work with UK Health Security Agency. There's also some work regionally through the Directors of Public Health to improve, but also to ensure that we've got our roles and responsibilities aligned. And that's as comes into that second area around the enablers. From a delivery perspective, the 4 areas of priority that we've identified are around the community infection prevention and control, particularly thinking around care settings, vaccination rates amongst children and adults, but particularly focusing on the inequalities in those vaccination rates, thinking about our particularly vulnerable groups who are most at risk, and that includes our migrant populations as well as our care home residents. And then ensuring that we strengthen the preparation for response to environmental hazards and emergency events, taking the learning that we've taken from the pandemic to ensure that we are better prepared for the future. So that's the final slide. So that was a summary of the strategy work. The Health Protection Board reports after each meeting in any case, but what I would like to do is to bring a report back each year on the progress with the strategy. We're very happy to have any questions.
Thank you, Robin. That's very comprehensive. We are asked to note this and to agree to receive updates at appropriate intervals, at least annually. I mean, as we've not had a strategy before, we're happy to take them biannually initially. Robin, perhaps? Are there any quick questions for Robin on this? No? Thank you. Thank you very much for that then, Robin. In that case, and thank you for that work. I'm just moving on rapidly, going to time. Now we're going to Richard Martin and Robin, who are going to talk to us about the effects of drugs and alcohol and give us the annual update, the work of the Derby and Derbyshire Drugs and Alcohol Strategic Partnership. Thank you.
I'm very happy to say Richard's offered to pick this up to give my voice a rest as well.
Thank you, everybody. I'm Richard Martin, Assistant Director of Public Health, and I'm responsible primarily for commissioning of substance misuse services, but I'm also a member of the Derby and Derbyshire Drug and Alcohol Strategic Partnership. Robin is the senior responsible owner for that partnership and reports to central government. And Councillor Martin, you will also sit on that board, so you'll have heard a lot of this before. Given that the recommendations are to note the work of the DASP over the last 12 months and to support engagement of partners, I'm going to take the liberty of going through this at pace because of the time and because there's a very large amount of information in these slides, so people can read that at their leisure, and there's an accompanying report. But I'll go through, as I say, at pace, pick out the salient features on what I need to impart on you. Next slide, please. I thought I'd give context as to what these jargons mean. The government launched a new drug strategy in 2021. That was based on an independent report a review conducted by Dame Carol Black. It's a 10-year strategy, a national strategy, or a national plan from harm to hope. obviously reviewed at 3-year cycles. One of the key strategic aims of that was that we had a different approach locally to strategically prioritising work in the areas of drugs and alcohol harm across a number of strands, and I'll talk about those. But we were told to form a combating drugs partnership in order to lead that work. So we have a Derby County-wide geography for our combating drugs partnership. It's known as the Drug and Alcohol Strategic Partnership. So frequently we use the word DASP, apologies for euphemisms. And our DASP, or our combating drugs partnership, was established in August 2022. And since then, we've done a lot of work, which the purpose of this presentation is to outline that work. But it's helpful if I give context, because when I was last here talking about this 12 months ago, and what we were talking about was the relative newness of the drug strategy and some of the requirements placed upon us. So this presentation kind of reflects those requirements set against the context of local development. Next slide, please. Our Drug and Alcohol Strategic Partnership is obviously aligned to the National Drug Strategy. We've chosen to focus on reducing drug and alcohol-related harm and deaths caused by drugs and alcohol, to reduce drug use, to reduce drug-related crime, and also to try and foster partnership-wide accountability in respect of the delivery of the National Drug Strategy to local level. That small, attractive spherical diagram demonstrates what our partnership is. It's a partnership with the police, senior police officers, senior probation officers, the Office of the Police and Crime Commissioner, NHS representatives at this moment in time representing all aspects of the NHS, public health from the city and the county as a unique partner, and then many local authority colleagues in various different disciplines and elected members. So it's a relatively senior partnership, and that partnership had chosen independently, there was no mandate to do this, to report to both health and wellbeing boards. It also will speak to or have a relationship with many of the integrated care partnerships or integrated care system structures, such as the integrated care partnership and place executives. So whilst it can have a degree of autonomy, it chooses to feed into those so that we highlight and almost proselytise the issues that we face in respect of alcohol and drug harm locally, and trying to gain support. I'm not going to go through the 3 strands of the drug strategy, but as you can see, they're to break the supply of drugs, to deliver world-class treatment, and to achieve a shift in the demand for recreational drugs at an intergenerational level. Next slide, please. This picture demonstrates the impact in respect of health and wellbeing and social care, prosperity and attainment, and the criminal justice impacts of substance misuse, drugs and alcohol. Why is it so important in Derby? Obviously, there's a similar presentation going to the county. Without stating the obvious, misuse of drugs and alcohol has a significant effect in relation to society, the harms caused, deaths, etc. Derby is relatively unique in respect of alcohol harm and alcoholic liver disease in the fact that we are worse than the national average, the England average. The deaths that take place in Derby due to drug and alcohol misuse are at the highest recorded level. That's outside of any recent anomalies caused by superpotent opioids. So we were on a trajectory, like the rest of the country, a bit higher, to have unprecedented levels of drug death. And worryingly, the numbers who present in primary and secondary care NHS services, who are then identified and referred into substance misuse treatment services, are low at best and are reducing. So this paints a picture that Derby is particularly disadvantaged when it comes to substance misuse and the impacts of substance misuse. That notwithstanding, the next slide focuses. Thank you. The next slide focuses on the benefits and the work of the DASP as a body or a partnership that has the ambition to create a shared vision with regards to tackling the 3 strands of the drug strategy. So if you consider the DASP alone, and since its inception, it's managed to create a relatively high-functioning partnership between police and other key stakeholders at a senior level in order to, as I say, look at resources, look at pooling their resources, sharing objectives, and taking a strategic view of substance misuse, whereas historically it's been a very parochial view. We've conducted needs assessments, and those needs assessments have complemented each other and resulted in a set of strategic priorities, which I'll identify in a moment, which are allied to the national requirements of the drug strategy. Like all boards, it's in an early state, but there have been some fairly positive developments in relation to its independence and its governance. We're recruiting an independent chair, creating a robust partnership agreement so that the activities of our partners are equitable and proportionate. And true to form, there are other artefacts of governance which are slightly bureaucratic but essential in relation to sharing information and developing outcomes frameworks. We in Derby City, specifically, because I'm both representing the views of the DASP and the views of the senior responsible owner, but also, as a constituent member of the DASP, I lead on treatment, and treatment is one of the drug strategy strands. So it would be remiss of me to say, or not to say, that we've had significant additional investment in respect of drug treatment specifically across the city and the county, on top of the investments that we already have. So we're in a relatively good position in relation to the funding of substance misuse treatment moving forward. Next slide. Some of our observations feeding into some of the other earlier needs assessment work are, and I'm going to go through these because you can read them when I circulate this. We're kind of on the back foot in all aspects in relation to crime, in relation to substance misuse related deaths, morbidity, mortality, and in relation to the uptake of some of those services. And these are just some of the snippets and the highlights from the needs assessments or the partnership needs assessments that demonstrate a need to coalesce our thinking and move forward. Next slide, please. Again, you can read these at your leisure. I'm not going to sit and read these verbatim, but we've got 4 overarching objectives. The first one is to reduce drug and alcohol-related crime and death. And you can see here that each of the partners around the DASP table have prioritised a set of strategic objectives in their own field of work, which complement one another. Speaking to Derby City Public Health, for obvious reasons, our strategic priorities are to reduce alcohol-related harm, to reduce death and alcohol-related mortality and morbidity, to improve treatment effectiveness and reach, make services appropriate and accessible, to improve the outcomes for individuals with co-occurring mental ill health. So the reason I've picked those out is because, not only with my hat on as the lead for substance misuse in the city, they are the priorities that we're working towards and using the investment from the Public Health Ring Fence Grant and the Supplemental Substance Misuse Treatment and Recovery Grant in order to fund additional work. Next slide, please. Other partners, including ourselves, are working to reduce drug use. I think reducing drug-related harm and reducing drug use go hand in hand, but they're quite distinct within the drug strategy. You could see that reducing drug use falls slightly into the remit of the police and the criminal justice system. Initiatives such as increasing drug tests on arrest, out-of-court disposals, greater use of treatment requirement orders in court, and improving continuity of care, which is when somebody leaves prison and within 3 weeks of leaving prison while they have a substance misuse need, they're picked up with the community. So a lot of work has taken place, and I think it would be quite boring for you and for me if I went through every aspect of that. So moving on to the next slide, and this just builds on the 3rd and 4th strategic objectives for the DASP around use of orders, continuity of care. There's some relatively exciting stuff taking place by the police, busting county lines, cracking down on drug supply lines coming in, targeting organised crime communities, and I would argue that the police have stepped into a space which is new and novel to them around recognising the harms that drug cause, not only the criminality. So I think at the next update, there'll be some very exciting information imparted about police operations, police culture change, and some of the benefits that we've had from operating in a partnership. Next slide, please. I think I've spoken a lot about that. This just talks to the police, again, stepping into uncharted territory. We're increasing the use of naloxone, a medication that reverses opioid drug overdose. There's training within the criminal justice estate. There's greater alignment between us all and the use of intelligence in order to seek out drug users. So I have to say, I've been doing this for 20 odd years, and it's the first time I've seen a concerted effort from key stakeholders to come together and to understand the gaps and to work together in concert in order to make significant change. Next slide, please. For us, against the backdrop of Derby being quite an outlier in respect of the harms, we've made some really impressive progress. I'm impressed with these figures, so I would assume that you're impressed as well because there's context here. We've increased our numbers in alcohol treatment significantly, notwithstanding there's a lot of alcohol-related harm out there, and we've got about 3,177 dependent alcohol drinkers, but we've made a good increase. 1,001 new presentations into treatment over the last 12 months, which is of note and significant. And there's a lot of emphasis at central government in relation to the links between drugs and crime. So 60% of prison leavers at local prisons returning to Derby community have been picked up and their treatment need addressed within 3 weeks, which is quite impressive, and 60% puts us as one of the best in the country. Next slide, please. Other progress from other partners, not specifically related to treatment. As I alluded to earlier, the police intercepted what's called a county line, which is a communication between an out-of-county body and an in-county host whereby drugs are supplied and vulnerable people are cuckooed. In doing so, the police averted a number of potential drug-related deaths. So, again, working together for the first time and recognising the link between treatment, drug-related harm and drug markets has borne pretty good fruit. Again, I think this just reiterates what we're doing. County lines, again, are the scourge of the country, and the police have developed a system called Clear, Hold, Build.
Richard, I'm sorry to interrupt. It is very good. We have been speaking for 15 minutes.
Okay,
so
well, I'll finish
now. I'm
now.
going to ask you to, we were short of time, but you have been speaking for overtime anyway. So if it is, can I ask you to
That's my last slide.
Sum up? Thank you. Oh, well, then.
Next slide. Last slide. I've started at this. The recommendations are to receive this information and receive an annual update.
Thank you. Thank you for that excellent report. I mean, I know there's quite a lot of work happening. I think, did you come to the last Health and Wellbeing Board, Robin, and report on this? I think ICP. Oh, it's the ICP. Yeah, sorry. I'm hearing this report quite a lot actually, because I heard at the ICP. I've been at the DAD. It is excellent work, and it is really important. So I am mindful of time. So just on this particular one, I would like to thank you for that and for all the work that you're doing. And it is really important because it is quite shocking to people, I think, when they realise the extent of the harm done by alcohol in particular, which is a socially acceptable form of drug. We know that I have views on why some are so socially unacceptable and others are socially acceptable. And the Director of Public Health doesn't necessarily agree with me. But anyway, quite seriously, this is a serious problem in the city, and it's good to hear that there's work happening on this. Eventually, we do need to move into a scenario when we are addressing that alcohol intake more clearly. But obviously, you're doing a vast amount of work already. Thank you. What I'm going to do is I'm going to ask if there are any questions on Richard's report. I think that also we have an option of taking Kirsty's report on the integration at the next meeting, but if people are able to stay for another 10 minutes, is the membership able to stay on for a little bit longer because we are running over time, which is entirely my fault. We can stay on and take Kirsty's report today. People happy to do that? Yeah. Well, thank you for your patience, everyone. We do have a really full agenda. So do we have any questions for Richard? Councillor Kerr.
It's really good to see so many different organisations coming together on this subject. So, long may it continue and move forward. The group that doesn't seem to be so embracing this is the community. And I'm thinking that it's something which as you're sort of settled into the way of working together, can we look at that side of it as well, because the drugs, particularly the drugs side of things, is something that the community is really concerned about. They see drug dealing in the streets, they see the police not doing enough on it, and there may well be community information out there that could be utilised. And there are also groups such as Alcoholics Anonymous and Narcotics Anonymous, which could be part of the solution as well. So it's really what work is potentially or already happening along those lines.
Thank you. Because of time limitations and because of I don't want to do death by PowerPoint, what we've not discussed is beneath that DASP, there are place-based groups. So there's a city group and a county group, and beneath those, there are in the city 5 or 6 governance groups within a different chair, well, a similar chair, that reflects some of the strands of the drug strategy from a health and wellbeing perspective. That architecture is replicated across every partner. So the NHS will have similar boards, the police will have boards, and within those, where the doing gets done, are community representatives. So that big thing at the top, where Chief Constable comes and the Director of Public Health is largely to set a strategic direction. Beneath that is a very sophisticated set of architectures which are geared to programme work, programme delivery, co-production, you name it, all of the other things that make good governance are within there.
Okay, thank you. What I'd suggest, I'm just going to take one more question if that's all right, because we are really running late. What I'd suggest, Richard, is one of the recommendations we receive an update. I think everybody would agree that we'd be very happy to receive an update. I suggest you bring it, you can bring us an update sooner rather than later. And what you could do is focus in that update, is focus more on what's happening on the sort of ground, at the grassroots level, in the way that Councillor Kerr has talked about. So give it that slant, and hopefully we'll have a less packed agenda at that time. So a question here then.
Thank you. Really fantastic work. We are a national outlier in terms of use, but this novel approach of intelligence-led approach to identify people who have not been referred, again, it's going to be a national kind of new initiative. Is there any thinking about how do we manage, because we will potentially open some floodgates? Have you thought about it, how we will manage that?
Yeah, we've often feared the concept of opening the floodgates. And for the many years that we've been doing that has never been the case, in the fact that it's probably the antithesis. We struggle to get people, even with population health management approaches and targeted approaches, into treatment, specifically for alcohol, because people don't think they've got an issue with alcohol. We had the same thing with iatrogenic addictions, that we would have concerns that as soon as we scratch the surface, there would be many hundreds and hundreds of people. That's not materialising. Whether it's confidence in the treatment system, or whether it's our perception of people's utility of services and their accessibility is different, we're not seeing that. Ask me again in 12 months, because we're about to start a pilot in primary care across a population base of about 60,000 people, where we use ultra-targeted population health management approaches to literally look at ICD-10 codes and pick people out and look at different engagement approaches. We'll cap the numbers that can come into treatment that way, but in reality, I'm not feeling that floodgate opening up, which saddens me, because there are, off the top of my head, 3,177 dependent alcohol users and 2,124 opiate and crack users, and we are only seeing 2,083 people in treatment, so there's a long way to go.
Okay, thank you. I'm going to allow one more question from the gentleman over here who hasn't. Did you want to, because you haven't spoken yet at all, I'm going to allow a question from you, and then I'm sorry, I do have to close the questions down because we need to move on quickly.
That's kind, Chair. Thank you. Gino Di Stefano, UHDB. Thank you for the presentation. It highlights just what can be achieved when partners come around a set of shared goals. It's just to say, despite prevention in relation to drugs and alcohol in particular being a key priority for the system, Derby more so for the reasons we've heard, there are other services in place funded by NHS bodies nationally that are challenged. So in the Royal Derby Hospital, we have an alcohol care team. Funding runs out in March. It's having a massive impact we must come together, as we are anyway, and continue to prioritise prevention. And wherever we can, although there's never enough money to go around, we have to make sure that these are the services that are sustained, not the services that face the cut when we're up against the wall because of the finances. So I just implore everybody to do all that we can to maintain these critical services, which in the past may have been the first to go because they are the ones that are considered optional. Thank you.
Thank you. I'm not sure if that's a plea to the ICB, is it? But I think, yeah, I'm not going to let you come back, Helen, I'm afraid, because I haven't got time. But there is in the system an increasing discussion about prevention and etc. It's just whether that can be sustained on the ground, as you say, with funding. But I think people have heard what you're saying. Thank you for that contribution. And thank you very much, Richard, for your report, which was excellent as always. And obviously you'll be coming back before 12 months to talk to us as we discussed before. Thank you for that. Kirsty, can you give your report in 5 minutes, or would you prefer to defer it to the next meeting?
Well, if people have read the report, I don't necessarily need to go through it. I could just talk through the recommendations, which could be a couple of minutes.
Well, my problem is I'm extremely familiar with this report,
I know,
so I feel I don't.
So are a few others, but not everybody will be.
Sorry?
I think the others in the room will also be familiar with this, but we can't assume everybody is as well.
Well, what I suggest then, on that basis, because it is important that we get the note on vaping and Health and Wellbeing Board, is that we do defer it then, Kirsty, if you don't mind.
That's fine. Well, it's not a decision today.
It's not a decision, no. We did have a decision to make earlier, or we had to discuss an issue at some length, or I felt we did. So that's why we've overrun slightly. So apologies. Thank you for coming. People have even longer to read this report now in full detail.
Yeah, next time I'll do
Kirsty
slides.
Will be expecting extensive questionings on this report, so no excuses next time. Thank you, Kirsty, and sorry that you've come along today and haven't been able to present. So, Robin, just a couple of minutes on vaping then, please.
Thank you. Just really briefly, the information is there in the pack. It's just to let you know that as Directors of Public Health across the East Midlands, we've developed a joint statement on vaping, just really to help to be really clear about the position, because it is a very complex area. So the information is in there to see, and we'd be really happy to have conversations around other organisations if people wanted to adopt that or to use those principles that we've got.
Thank you, Robin. And this item is just for information only. I'm sure people will always take questions by email outside of this meeting. It can always be brought back. Because we do have a forward plan, don't we, as Alison Wynne is probably about to refer to.
Yeah, shall I move straight on to that? So, yeah, so very just brief for information, and this report is just highlighting two things really. So the first is kind of ongoing work around the health and wellbeing strategy, and just to bring to attention of members that we are looking to put in a facilitated workshop pretty soon in the next couple of months to support that strategy development. So please look out for invitation coming for that. And then the second point is that you just alluded to, Chair, is around the forward plan. So in 4.3 there is highlighted kind of agenda items that we've penciled in for the next meeting. And obviously following on from today, we've got a number of reports to forward plan for upcoming meetings, so we'll do that. But just ask if there are any other items for the next or other upcoming meetings, just to let me know. Thank you.
Right, thank you very much, Alison, and thank you, Lindsay, for your support, and thank you all for coming. I'm sorry we've overrun slightly. It's actually only 10 minutes in the end. And thanks you all for your contributions, and we'll see you in a couple of months' time. Thank you.